Good morning, everybody. Welcome to Grand Rounds. I'm sorry we're starting a little bit late. We'll have a land acknowledgement with our talk. It's a pleasure today to introduce one of our recent post-grad graduates who's now on staff in the Division of Geriatrics, Natanya Russek. As you can see from her the slide, she's now doing a UBC Cognitive Neurology and Dementia Fellowship, which I suppose will support this talk. So welcome, Dr. Russek.
Thanks, everybody. Thank you for the introduction, Dr. Casson. Again, my name is Natanya. I'm a geriatrician here at St. Paul's. And as Dr. Casson mentioned, I'm also completing a fellowship at UBC, but I'm really looking forward to working with you all once my fellowship's done at the end of this year. So I'll be on the wards in January. I think this is some really nice timing that this is the date of this talk, because the newest anti-amyloid antibody drug was actually just approved about 3 weeks ago here in Canada. So I think that this is really the forefront of dementia clinical therapeutics. And I'm hoping that you will find this topic as interesting as I do. So our land acknowledgement will begin by acknowledging that the land on which we gather today is the unceded territory of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. So I'll start by my disclosures. My fellowship was funded by the Alzheimer Society of British Columbia, though they did not review my slides at all. I also want to acknowledge that while I'm very happy to collaborate with the drug companies in order to get these medications to patients, this presentation very proudly reflects my own interpretation of the data, though I will, in full disclosure, say that I had quiche with them this morning over breakfast to talk about how to get lecanemab to patients in BC, for which I am also grateful, because we cannot do this without the collaboration of the resources from the drug companies. And I will be talking about this class of drugs called anti-amyloid therapies. There are two that we'll be talking about. Lecanemab, which was just approved by Health Canada 3 or 4 weeks ago, and donanemab, which remains under review by Health Canada. And I want to be clear, I'm not talking about off-label use here. Like this, you cannot get donanemab here in Canada. And I know we are a small but mighty audience, but before we go forward, I'm wondering if you've heard of these drugs or this class of drugs, if you could just raise your hand so I know who's here. Okay, a lot of like hand wavy. That sounds about right. So hopefully at the end, you'll confidently raise your hand and say that you are familiar with what to expect for these medications. So these are the objectives. We're going to go through the biological rationale for targeting amyloid and Alzheimer's disease. We will talk about efficacy and safety data, how to apply the benefits and risks of therapy to our patients, and go through some clinical and logistical challenges. So I want to start with a theoretical patient visit. I want you to imagine that you're working in any internal medicine specialty clinic and you're seeing a patient. If everybody could please mute themselves, that would be so great. If you could please mute yourself, that would be so great. Okay, super. Thank you so much. So imagine you're working in an internal medicine clinic and you're seeing this patient, Jean, for some other unrelated reason. And you see in her referral package that she does have a history of a diagnosis of mild cognitive impairment made by her family doctor. And she is presenting to you for some other reason, but because you are a specialist, she asks you what you think about this new drug that was just approved. And I think that's a very valid question. I think as internists and across subspecialties, people will turn to us as content experts, even if it's not really our area of expertise. So what I'm hoping that we can do is go through the information that you would need in this clinical encounter, even if you're never going to be a prescriber of these drugs. So we're going to start by first setting the stage for our discussion. Alzheimer's disease, or AD, is not just one of the causes of dementia. It's both a clinical and a biological entity. According to the 2024 Alzheimer's disease classification criteria, Alzheimer's disease is a biological process that starts actually long before we see clinical symptoms. We know that the biological changes happen in the brain 10 or sometimes 20 years before somebody presents clinically. Over time, people will emerge with clinical symptoms that impair their cognition and their function. The idea essentially is that Alzheimer's disease exists on a continuum. On one end, you have people who are completely asymptomatic but have changes in their brain. Then we have people who have mild cognitive impairment, meaning that they have cognitive changes, but it does not impair their daily function. After that, the disease can progress to what we would call dementia, where people have cognitive impairment that impairs their daily function. From a clinical standpoint, we assess the severity of dementia by going through patients' functional status. Mild dementia is defined as somebody who has impairment in their independent activities of daily living, things like driving or managing finances because of their cognitive impairment. And moderate dementia is when basic activities of daily living are impaired because of cognitive impairment, things like bathing and transferring and feeding. The neuropathological hallmarks of Alzheimer's disease are extracellular amyloid plaques and intracellular tau tangles. In typical Alzheimer's disease, amyloid beta or A beta deposition begins when the amyloid precursor protein is cleaved into peptides of varying lengths. These cleaved oligomers are then processed and modified, and they start to accumulate in the brain, resulting in neurotoxic extracellular neuritic plaques. And you can see on the top left, like a drawing or schematic of what a neuropathology slide would look like. These plaques are first found in the medial temporal lobe, which houses the most important structure for memory, the hippocampus. And then after that, you will begin to find these plaques accumulating throughout the cortical structures. And you can see the way that this progresses in the top right. The next key protein in this process is called tau. This is a protein that's normally found inside of neurons, and it helps with stabilization of microtubules. According to the amyloid hypothesis, the accumulation of A beta will trigger the tau to become hyperphosphorylated, and that causes the tau to accumulate inside of the cell bodies and the dendrites as neurofibrillary tangles. And you can see that on the bottom left neuropathology kind of diagram there. In Alzheimer's disease, these tangles, very similar to the amyloid beta plaques, also begin accumulating in the medial temporal lobe and then subsequently go out to the cortex. So you can see that kind of classic schematic on the bottom right here. And this framework is what we call the amyloid hypothesis. And it's the current leading theory of Alzheimer's disease pathogenesis. There is debate in the literature. There are other theories that probably contribute, but this is the leading theory. And it became kind of known in the literature in the 90s and was officially kind of the predominant theory in the literature by the early 2000s. The diagnosis of Alzheimer's disease has long been a clinical one. That means somebody who's trained sits with the patient and talks to them and does an assessment and makes the diagnosis. But increasingly, biomarkers are being used to support both the diagnosis of dementia and specifically what that causes, something like Alzheimer's disease. Here on this slide, you can see pictures from an amyloid PET scan. This is used to confirm the presence of Alzheimer's disease pathology in the brain. Here in British Columbia, these scans are not really available at all. They're definitely not available clinically. We use other types of measures, which are beyond the scope of this talk. But I show you this because this is what the two trials use. So this will be their main outcome that we will be talking about. For many years, and based off of some earlier hypotheses about Alzheimer's disease pathogenesis, the only available treatments for Alzheimer's disease were cholinesterase inhibitors, drugs you probably are familiar with, things like donepezil, rivastigmine, and galantamine, and we still use these today. Memantine, which is an NMDA receptor antagonist that you can see on the far right, is only approved for patients who have moderate to severe Alzheimer's disease. And the cholinesterase inhibitors are only approved for people who have dementia. So there's a real gap in treatment for patients who have mild cognitive impairment or preclinical disease, so patients who don't have symptoms. By the early 2000s, the amyloid cascade, as it was becoming better understood, researchers were interested in trying to intervene on this process directly to try to actually modify the disease trajectory. So a lot of people talk about these new drugs that we'll be talking about as actually disease-modifying therapies. Amyloid immunotherapy was first explored in the early 2000s with the idea of the amyloid cascade becoming more popular in the literature. Early animal-based studies showed that these antibodies could very effectively lower amyloid from the brain, and they also were found to improve behavioral measures, things like memory testing. The current anti-amyloid monoclonal antibodies in use are called lecanemab and donanemab, and you can see them highlighted on the screen here. They act on different steps of the amyloid processing cascade, which is a bit simplified but demonstrated in this diagram. What they do is they bind to the amyloid in the brain and they remove it, clearing the brain from that cerebral amyloid burden. As I mentioned earlier, in October, Health Canada approved lecanemab for use in patients with early Alzheimer's disease, mild cognitive impairment, or mild dementia. And as I mentioned, donanemab remains under review by Health Canada. We are expecting a report from them in the coming days, weeks, months. These treatments can be very beneficial for the patients who are selected very carefully, and patients who are willing to undergo all of these treatments, their infusions, people who are willing to undergo strict monitoring protocols. And it's really important to have a shared decision-making discussion with your patients when talking about these medications. So we're going to go through a bit of the literature. This is not a journal club, I recognize, but there are only 2 articles really on these trials. So we're going to do like a very abbreviated journal club, because I do think that like the patient population and how the studies were run is really important for integrating these drugs into our practice. So if you'll humor me, the first thing we're going to do is talk about a test that you may not have heard of called the Clinical Dementia Rating Scale, or the CDR. This is one of the key tests that are used in Alzheimer's disease and other dementia clinical trials. And it's one of the key clinical outcomes. And so that's why I think it's important to get actually a fairly detailed sense of what it means. So the CDR is a very structured way to assess cognitive and functional impairment in our patients. It's based off of clinician judgment with an interview with the patient and the caregiver. There's no paper and pencil test involved like the MOCA or the MMSE. It's all based off of interview. And as I mentioned, the CDR is really just used in research settings. There are 6 domains of cognition and function that are integrated into this assessment. There's 2 different ways to interpret the CDR. The first is called the CDR Global Scale, and it gives sort of an overall stage of disease. Each domain is assessed and given a score on the scale. And then there's like a fancy algorithm that's used to determine what the average is. It's not actually an average, it's a more fancy average. Scores run from 0 to 3. 0 is normal, so no cognitive impairment. 3 is the most severe cognitive impairment. And there are some clinical correlations with this test. So a score of 0.5 is felt to be a representative of mild cognitive impairment, and a score of 1 is felt to be representative of mild dementia. The second way to look at this test is called the CDR Sum of Boxes. And what this does is each domain gets a score, and then it's just added up. So 0 is normal, and 18 is the most severe, because there's 6 domains with the maximum points being 3. So next we'll talk about the 2 clinical trials that were used for these drugs. Both of these trials were multi-center, randomized, double-blind, placebo-controlled, phase 3 clinical trials recruiting for international research centers. All participants in the study had biomarker confirmation of Alzheimer's disease. The lecanemab study, which you can see on the left, was called Clarity AD, and it was published in NEJM in January of 2023. The average participant in the study was 71 and was white, and there were 1,800-ish participants enrolled in the trial. About half of those patients were women, and on average, people had mild cognitive symptoms consistent with mild cognitive impairment. And you can see some of the numbers there. We talked about the CDR Global and some of boxes, and then the MMSE average was 25. The donanemab study on the right was called Trailblazer-ALZ 2, and it was published in JAMA in July of 2023. The average participant was a little bit older at 73. They were also predominantly white, and 57% were women. Participants in this trial tended to be a bit more impaired at baseline than in the lecanemab trial, with an average CDR Sum of Boxes of 4 compared to 3.2, an average MMSE of 22 versus 25. Some of this is how they recruited and their inclusion criteria, which we could talk about length, but I'll just leave it there. Something that's interesting about the trial is they summarize in the donanemab trial that 80% of those patients had mild dementia, but the way that they define that was strictly based off of the MMSE score. And we know that that's not like how we do this in clinical practice. What we do is what the lecanemab trial did, which is you have a clinician sit down with the patient, go through their testing, go through their symptoms, and come up with a clinical diagnosis. All of those caveats being said, the patients in the donanemab trial were a bit more impaired. What label you put on it is kind of notwithstanding. In the Clarity AD trial, the intervention treatment was lecanemab as an infusion every 2 weeks for 18 months versus placebo. The Trailblazer study randomized participants to receive donanemab infusions or placebo every 4 weeks. To reduce early side effects that had been seen in some of the earlier phase trials, they used a graded titration schedule. So the first 3 doses were half dose, and the 4th dose and subsequent dose were full doses. And this trial lasted for 76 weeks. Again, to reduce the risk of some of the side effects that we'll go into detail later that they were familiar with based off of earlier trials, they had a dose responsing strategy based off of results of amyloid PET scans. So at 24 and 52 weeks, each participant had an amyloid PET scan. And if their amyloid PET was determined to be essentially cleared based off of some predetermined guidelines, they were switched in a blinded fashion to placebo to continue the rest of the trial to 76 weeks. There are several key limitations to keep in mind about these patient populations. I think like most clinical trials, like these are a very, very, very highly selected group of individuals. And I think that they can reflect some differences between who we see in the trials and who we would see in our clinical practice. Everyone was required to have a study partner, and everyone had to be able to give informed consent themselves. Some of the example exclusion criteria I have highlighted in the chart on the right. Participants had to be assessed from a comprehensive perspective, and they were not allowed to have any active or untreated neurological, psychiatric, or medical conditions that were felt to be contributing to their overall wellness, their brain health, their cognitive status. Patients were very carefully selected to only have one pathology thought to be causing their dementia or their cognitive symptoms, and that's Alzheimer's disease. So anyone who was thought to have co-pathology with, for example, vascular dementia or Lewy body dementia, they were all excluded from the trial. We also don't have patients' data on frailty or multimorbidity. And as a geriatrician, I care about that a lot because that helps us recognize how transferable these patients are to our general population. We know that the general patient population in these studies is less frail than who we might see in our clinical practice. Regarding race, 75% of the patients in the lecanemab trial were white, and 95% of the patients in the donanemab trial were white. And additionally, while education data was not reported for the lecanemab trial, in the donanemab trial, 70% of the individuals had at least 13 years of education. So this is just my caveats that I have summarized here. There's others that we could talk about, but I do think it's important to frame this for generalizability and external validity. So next we'll talk about the study outcomes. I will start by just orienting you to the graphs. On the left, you can see the lecanemab graphs, and on the right, you'll see the donanemab graph. The x-axis for both is time. The lecanemab trial was run for 18 months, and the donanemab trial was run for 76 weeks, which is 17 and a half months. So it's pretty similar in the time frame. On this slide, we'll go through amyloid PET clearance. The y-axis is centiloids for amyloid PET. It's like a heat map interpretation of the PET scan from earlier, essentially. And you can very clearly see for this outcome, which was a secondary outcome in both studies, that amyloid PET was very effectively cleared from the brain in both studies. You might be curious for the donanemab trial, which had that dose responsive strategy. 66% of the patients who were receiving the active drug in that trial actually were switched to placebo by week 52. So this is very effective at approaching the biological endpoint of removing amyloid from the brain. Next, we'll talk about a clinical outcome. It's the CDR sum of boxes. If you remember from a couple of slides ago, the score ranges from 0, which is normal, to 18, meaning the most severe. And this was the primary outcome in the lecanemab trial, and it was one of the secondary outcomes in the donanemab trial. The x-axis is the same in these graphs. It's time, same as the last slide. The y-axis shows the adjusted mean change in the CDR sum of boxes from baseline. And you can see that all groups, treatment and placebo, had declined. And this is expected based off of the natural history of Alzheimer's disease, and also because we know that this treatment is not a cure. It modifies the trajectory of clinical therapy. So this was not unexpected. What you can see in both charts from both studies is that people who received the active drug, which is conveniently in yellow for both, they all had a less decline in the CDR sum of boxes over the course of the study. The difference in the CDR sum of boxes for lecanemab, sorry about that black box, hold on. Okay, there we go. So for lecanemab, it was a difference of 0.45. Again, this is the scale of 0 to 18. And for donanemab, it's a difference of 0.67. There is some open label extension data published for some clinical outcomes. Sorry, it's not published, it's been presented at conferences, but because it's not published in peer-reviewed journals, I haven't featured that data here because this is what the average person going through the literature has access to. But if you want to talk about it at the end, I'm happy to answer questions. The primary manuscripts report rates of slowing of disease progression based off of the hazard ratios from this data for 25% for lecanemab and 32% for donanemab. So this is all great, but I don't know about you, but if I had Jean, our patient, sitting right here, I have no idea like what this actually means for Jean. Like what is 30% slowing of Alzheimer's disease? So there's a few different ways we can explore this. One of them is doing a time to event analysis. Both trials actually reported the time to event analysis as an exploratory outcome. A time to event analysis basically looks at how long it takes for a thing, an outcome of interest to occur. And here that is worsening on the CDR global. If you remember, the CDR global is 0 to 3, and each step reflects like a clinical progression, 0.5 to 1, MCI to mild dementia. So you could make an argument that a worsening of an event on the CDR global is clinically meaningful. On the left, you can see for lecanemab, these patients had about a 30% lower chance of progression over 18 months versus placebo. And for donanemab, it's a bit higher, 37% chance, again, over the same time frame. Another concept that we can explore to help derive some clinical meaningfulness from this data is called a time-based analysis. Essentially, the concept here is visually demonstrated on the left. We're just looking at how much time is saved in the treatment group versus the placebo group. And this is especially helpful for a treatment that is not preventing something from happening, but slowing the rate of progression, where it's kind of harder to quantify for the person sitting in front of you. Based off of some analyses of the primary studies as well as expert opinion, lecanemab is anticipated to save a patient about 4 to 5 months of progression-free time over 18 months, and donanemab about 5 to 6 months of progression-free time over 18 months. So that feels like something you could actually tell somebody sitting in front of you. One question that's very commonly explored and, to be honest, hotly debated in the literature is whether these results are clinically significant as well as statistically significant. There's a concept called the minimal clinically important difference, which basically talks about the smallest change that would be measured on a clinical outcome that a patient or a clinician or their family members would find significant. The CDR sum of boxes has some kind of agreed upon definitions for a MCID, which ranges from 1 to 2, depending on the severity of disease stage. You can very clearly see that these numbers are below this cutoff, and this has led to a lot of debate in the literature. It has opened a lot of questions about the validity of the MCID and also what it means to use this data from one clinical trial with 1,800 very carefully selected participants and apply it to our patients. So I leave this here as food for thought, so that we can have a nuanced but yet critical and thoughtful conversation about this outcome data, because not every person who's going to be eligible for this treatment will want to go through it, and there are real side effects that we have to talk about. So that's what we're going to start with next, is the safety data. The most significant complication associated with anti-amyloid therapy is called ARIA, or amyloid-related imaging abnormalities. ARIA refers to changes that are seen on an MRI of the brain. ARIA occurs in patients on anti-amyloid therapy because the clearance of the amyloid from the brain also involves clearance of vascular amyloid, which we know of occurs in things like cerebral amyloid angiopathy, and we know that many patients with Alzheimer's disease with classic presentation of memory problems also have some amount of amyloid in their vasculature in their brain. By removing this sort of like off-target amyloid, it's thought to cause some vascular leakiness or permeability, predisposing people to having edema or hemorrhage. And that's the two classifications of ARIA, is ARIA-E for edema and ARIA-H for hemorrhage. The most important thing to monitor in these symptoms in these patients is these lists of symptoms, and it's like a long list of neurological symptoms. It includes things that can seem quite benign, like headache, all the way through focal neurological symptoms, seizures, delirium, etc. And these can happen and be symptomatic from both ARIA-E or ARIA-H, although most cases of ARIA are asymptomatic and resolve with adjustment to treatment protocols. In this chart, I've shown the ARIA-E rates from both of the trials. The teal bars represent the symptomatic ARIA events, and the dark green bars represent the asymptomatic ARIA events. You can see here that though ARIA was common, the rates of symptomatic ARIA-E was less common. So in the range of 2 to 6% for ARIA-E. For ARIA-H, similarly, rates of ARIA-H were common, up to 30+% in the donanemab trial. However, the rate of symptomatic ARIA-H was actually rare, around 1% in both trials. Among all people who experienced an ARIA event, ARIA-E or ARIA-H, severe adverse events, like defined officially in clinical trials as like hospitalization, death, and some other outcomes, were actually quite uncommon, 1% in the lecanemab group and 2% in the donanemab group. You may be wondering why there was more ARIA in the donanemab group versus the lecanemab group. There's a few theories as to why this could have occurred. One is, if you remember, the patients in the donanemab group were a bit more progressed in terms of their clinical stage. According with the hypothesis and biomarker data, this should mean that they have more amyloid in their brain and would be at higher risk of having an amyloid removing related event like ARIA. The second kind of contributor is a mechanism thing about the drug. So donanemab has more off-target binding of vascular amyloid than lecanemab. There's other reasons, but those are two of the primary ones. And there are some modification trials with even further dose adjustments, which kind of normalize or equilibrate the rates of ARIA from donanemab to similar to the lecanemab group. One very important risk factor for ARIA is genetic. ApoE4 is a genetic risk factor for Alzheimer's disease. People can carry 0, 1, or 2 copies of the ApoE4 allele. And the number of copies is directly related to both Alzheimer's disease risk as well as onset age for Alzheimer's disease. In the context of anti-amyloid therapy, as you can see here, ApoE4 carrier status is actually very strongly associated with ARIA risk. Carriers have up to a 5 or more times rate of having an ARIA-related event than non-carriers. And this is safety data from the lecanemab trial, which kind of quite neatly demonstrated almost like a dose-dependent risk. So the other thing to note is that most patients who had symptomatic events also had ApoE4 carrier status. So they are the most important people to monitor for. And this is also why the drug labels, including the one just released in Canada for lecanemab, they actually exclude ApoE4 homozygotes from receiving lecanemab here in Canada. To wrap up the safety data, I want to just briefly touch on some other adverse events in the trials. Infusion-related reactions were common. This is not surprising. Monoclonal antibodies, we give them for a variety of drugs. They cause flu-like reactions, rashes, hypotension, and the overwhelming majority of these reactions were very mild and did not require presenting to a hospital. They were just managed in the infusion clinic. But they were common. A quarter of patients receiving lecanemab had one, and a tenth of patients receiving donanemab had one. Very serious adverse reactions in general, like hospitalization, occurred at about similar rates between the treatment groups and the placebo groups. And death was uncommon in both trials. In the lecanemab, none of the deaths were felt to be related to ARIA or related to the drug, related to other things, in the patient population. In the donanemab trial, deaths occurred in about 2% of patients, and 3 of the 16 deaths were attributed to serious ARIA-related complications. So this is a very serious concern that is worth noting. So to summarize the side effect profile, it's not trivial, but it is predictable. And the highest risk scenarios are really concentrated in people that we can risk stratify for, and in people that we would, unfortunately, but realistically, remove their eligibility from accessing this drug. So most people with appropriate screening and monitoring can receive this drug fairly safely. So you may be wondering how these drugs compare to what we already give patients, cholinesterase inhibitors. We do not have head-to-head trials, and I'm going to start with like a whole list of caveats for this data, okay? So the first thing is there's different mechanisms, and it's not just like they work on different pathways in the brain. We think that cholinesterase inhibitors are symptom-based therapies that sort of transiently improve someone's quality of life and cognition, but that benefit is not as longitudinal as we think that anti-amyloid therapy benefit will be, which we generally think as, and experts generally refer to as, like a disease-modifying therapy. So you're sort of comparing apples and oranges in some ways. enrollment criteria has also changed so much in the past 20 years. The patients in the cholinesterase inhibitor trial, they were diagnosed with Alzheimer's disease clinically, and the patients in the anti-amyloid therapy trial were all required to have biomarker confirmation of Alzheimer's disease. So the patient populations are not as cleanly comparable. Another limitation is that participants in the lecanemab and the donanemab trial were allowed to be on cholinesterase inhibitors, as long as the dose was stable before they started enrolling in the trial. About half of participants in both of the studies were on a cholinesterase inhibitor, and this was included as risk stratification for treatment versus placebo for randomization. I would love to see the data on the outcomes for this subgroup, but this is not published. Lastly, the other thing to note about this data is that it's based off of what we have in the research, and the time frame is different. So while you can see that the time saved looks similar, the time saved for lecanemab or donanemab is over 18 months, and the time saved for the cholinesterase inhibitor trials is 6 months over 12 months. So it's like a slightly different framing, but all those caveats being said, this is what we have. So this is what we're going to work with. As we discussed earlier, an important consideration is the patient populations are different. Lecanemab would be approved for patients with mild cognitive impairment or mild dementia due to Alzheimer's disease, and cholinesterase inhibitors only covered for patients who have dementia due to Alzheimer's disease. They're not found to be effective in a Cochrane review for patients with MCI. As you can see, the time saved is actually fairly similar, with the caveat that the time over which that time is saved is different. And the number needed to treat for cognition and function is actually pretty similar. And to be frank, these are pretty good. So for comparison, the number needed to treat for anticoagulation for preventing stroke in patients with AFib is 24. And I don't think any of us in this room would like blink an eye at giving somebody an anticoagulant for stroke. So I think that's really important to compare. Lastly, I'll just talk about cost. These drugs are so expensive. And this is just the cost of the drug. This does not include administration time, MRIs, PET scans, like you name it, does not include any of that. We don't have the official numbers on what this drug will cost in Canada, but in the US, lecanemab costs $26,000 a year. Cholinesterase inhibitors cost a lot less than that. Depending on which one you're on, it can cost between a few hundred and up to like $1,500 or $2,000 per year. So the actual cost of these drugs is significantly different and worth considering. We do not know what drug coverage will look like for lecanemab. That is yet to be determined. Next, for number needed to harm, cholinesterase inhibitors, for any side effect, the number needed to harm is 12. This is why we are not that reluctant to stop people from taking a cholinesterase inhibitor if they have side effects, because the number needed to treat and the number needed to harm are pretty similar. And this any side effect kind of bucket for the number needed to harm for cholinesterase inhibitors also includes the kind of most feared complications and rare complications like syncope or heart block. The number needed to harm data for lecanemab is only available for ARIA-related complications. The number needed to harm to have an ARIA-E or H event is not that high, but the number needed to harm to have a symptomatic ARIA-E event is actually fairly high. You'd have to treat 86 people with this drug to have a symptomatic ARIA-E event. There is no data that I was able to find on the number needed to harm for any side effect of lecanemab, but not having crunched the data myself, I can tell you with confidence it would almost certainly be below 9, because there's a lot more infusion-related reactions and other side effects that were reported in the trials. But what's really important to note is that these were like a carefully selected patient population, but the the lecanemab trial did include people who we now know are higher risk, like ApoE4 carriers, including ApoE4 homozygotes. So it's also possible that this risk could be less in the real world patient population. So we are working right now on referral pathways and how to get access, and there's a million logistics, but I'm just going to briefly talk about what the logistics kind of in theory look like based off of clinical experience, as well as some appropriate use guidelines that are published in the literature. Before starting anti-amyloid therapy, it is essential to do a thorough pre-prescribing assessment. The patient must have a clinical diagnosis of mild cognitive impairment or mild dementia, and they must have biomarker confirmation of Alzheimer's disease. Here in BC, that will mostly be done with plasma, like blood-based biomarkers or CSF. They also need to be willing and able to go to a lot of appointments. This includes a lot of MRIs, which are necessary for monitoring for ARIA. And the kind of sample schedule that we probably will be using here in BC is provided on the bottom right. And this is just like a lot of appointments in addition to every other week or every month infusions, in addition to blood work, in addition to. So this is like a very high healthcare utilization type of experience, and patients have to be willing to go through with that. They also have to be reviewed from a medical standpoint, make sure that they don't have any other kind of active or contributing diseases to their symptoms, no active psychiatric disease that could be causing their cognitive impairment. And they also have to go through a couple of steps to reduce ARIA risk, which we'll talk about on the next slide. So to reduce ARIA risk, the first thing is genotyping for ApoE4, and this is now available here in the province at a highly subsidized cost in collaboration with some of our colleagues in clinical chemistry. And unfortunately, homozygotes will not be eligible for lecanemab right now based off of what we know. All patients also must have a pre-treatment MRI reviewed. I've left some images of some of the findings. These are kind of extreme ones, but they're for your reference. I do always encourage everyone to look at their own brain scans, but you can see some examples of some of the imaging exclusion criteria, things like superficial siderosis, multiple microhemorrhages, and definitely a lobar hemorrhage. And if you're going to order an MRI scan for a patient that you're thinking about putting on one of these treatments, or you think this MRI might be used for somebody to become eligible, then our colleagues in neuroradiology have suggested you just write on the order form, like considering anti-amyloid therapy, and they will publish a comment in the report about it. This is in the Lower Mainland. Additionally, there's present guidelines on the drug label in Canada against the use of anti-amyloid therapies in patients who are on anticoagulation, which is a huge portion of our population. There's probably more data that will need to be explored for this, but some of the reason that this is on the drug label is because there have been some really horrific outcomes in patients on anti-amyloid therapy who got thrombolytics for stroke and suffered a catastrophic intracerebral hemorrhage. So I think as an internist or as another subspecialist who might be working in the eMERGE at St. Paul's or otherwhere in the province, it's really important to know if your patients are on these treatments, because we don't know really about thrombolytics for PE. We don't know about thrombolytics for MI, and we can't safely 100% say that these people should get those treatments. When possible, obviously endovascular type of therapy would be better, but I would recommend just talking to your colleagues in neurology if you're at all worried. And if you have anyone who comes in with symptoms, then later on, we'll talk about some of the MRI protocols. There is some uncertainty about what to do for patients who are on antiplatelet therapy. What's really interesting is there was no signal for harm or increased ARIA events for patients who are on antiplatelet therapy in the studies, but we also don't know. So the guidance that I've been given and that I've read through in some of the literature is that basically you just have like a risk-benefit discussion with the patient in front of you, which is, I think, stressful, ambiguous, and requires careful consideration. So when managing side effects, any neurological symptoms in a patient on anti-amyloid therapy, they should have an MRI. They should be assessed urgently for ARIA. Any acute changes included here: headache, delirium, especially things like focal neurological symptoms or seizure. And this means getting an MRI with diffusion-weighted imaging, because the overlapping presentation for an ischemic stroke and ARIA is quite prevalent. Early corticosteroids can be considered in patients who are more symptomatic, especially if they have ARIA with edema. And depending on the severity, some patients might need to be admitted to the hospital. And I do recommend consulting with neurology and reviewing the images directly with our colleagues in neuroradiology before considering any therapies. There are a number of broader considerations to think about for these drugs, from the healthcare system to our individual patient. Lecanemab is quite expensive, and it is quite expensive relative to its actual benefit that we know of clinically. There's one study that I found that did an economic analysis, which I was very eager to read, and this was published in the journal Neurology last year. And they looked at a bunch of system-based factors and the population benefit, and they estimated that in order for lecanemab to be beneficial for quality adjusted life years in the population, it should cost $5,100 annually US or less. Very clearly, this is a lot more than that, and that's only the cost of the drug. We also, as I mentioned, don't know who's going to be funding the drug, the province, if it's just private, if extended health benefits will cover it. We don't know quite yet. So there's some access questions and equity questions that come up specifically around finances. These treatments also are anticipated to place additional demands on our healthcare system, which, as you all know from working on CTU and the frontline, is already stretched. What I think is something that we don't often think about is that a lot of people with cognitive impairment actually don't present to care because they kind of think nothing can be done. Having heard about these treatments, there may be more people presenting to care to get assessed. And not only that, they need to be assessed urgently and in a timely fashion so that they do not surpass the eligibility window to get access to these drugs. So everything from our hospitals, our healthcare system, our clinics, primary care providers, everyone's going to have to change how we think about these patients. There's also personal costs for patients and caregivers, time away from work for caregivers, time to travel to get treatments. It's hard to quantify what this will look like for an individual patient. And for some people, this won't matter. They'll throw anything at this disease because it's devastating. And for some people, it will impact their quality of life and might give them pause. So in short, there's a lot of complications and considerations here that are financial, logistical, and personal. But to be honest, like, we have done this for other diseases. We have implemented monoclonal antibody therapies that require monitoring for things like MS, for Crohn's. We have a robust cancer care agency that does infusion treatments for patients all the time. And we can accommodate this. The healthcare system may have to be in a kind of a necessity is the mother of invention type of situation. There are several exciting developments in the field that are underway. There's a really much anticipated trial called the AHEAD trial, the kind of graph is on the left. And what this is doing is it's enrolling people who have biomarker evidence of Alzheimer's disease but are asymptomatic to get lecanemab. So it's really exciting, and if so, would be a real proof of concept for the amyloid cascade and the pathogenesis. There's also a number of drugs in development modifying the monoclonal antibody structure to reduce ARIA risk. One of these drugs is called trontinemab on the right, and it uses an active transport kind of structure to get across the blood-brain barrier, and it has been shown to reduce rates of ARIA in some earlier phase clinical trials. There are a lot of questions. There's a lot we don't know. There's a lot we don't even know about just getting access to these treatments. Although the drug has been approved, it's probably going to be at least weeks, if not a few months, before the first patient gets therapy here in BC. I think as a geriatrician, I have a few kind of key questions, like, will this apply to my patient population? How eager will people be to take this drug? A lot of people do take this drug in the US, where this is already accessed. And then who will this apply to when it comes to like actual patients in front of you, like people who have co-pathology, people who are outside of the range of the ages, people who are from different backgrounds, people who are multimorbid and frail. Like, what is this actually going to look like? And I think we have yet to see what some of that real world data will look like. So we come back to our patient Jean. What would you tell her, or when would you actually prescribe should she be found eligible? And the really short answer is this is going to be shared decision-making with the patient. It's going to be considering what is most important to the person in front of you, and what does this data mean to them? For some people, spending all this time in the hospital is not how they want to spend their time. For other people, that does not matter, and neither does the risk, because Alzheimer's disease is a devastating disease with a guaranteed decline. And so many people will take this drug very willingly and accepting the risk, because we risk stratify them, we monitor them, and we do our best to try to enhance their quality of life and buy them some more time. It's very important to set clear expectations with patients. Unfortunately, this is not a cure. This is a disease-modifying treatment, and patients will continue to decline, which remains quite frustrating, and we'll have to see what other kinds of therapies come down the line in future studies. But in the meantime, please stay in with your ear to the ground for updates on the referral process and some other logistics, because it's kind of yet to be determined. So I want to say thank you to inviting me to give this talk. These are my grandparents, and this is why I got into this line of work, as I think many people in geriatrics did. So I'm eager to take your questions, and I hope that you were able to learn something.
Is there anybody online that has a question?
Yes, I do.
Go ahead.
Yep, go
Oh,
ahead.
hi there. Great. Thanks. Thanks for an excellent presentation, Natanya. I just was wondering if about access to the CSF or the serum testing for biomarkers of Alzheimer's. Is that something I've been getting asked questions about, and I was wondering if that is something that's available here in BC.
It is available in BC. The way to get CSF testing, there's a kind of a long and a short story, and I'm happy to email with you about logistics. But the short version of the story is CSF biomarker testing is mostly done at the Alzheimer's clinic at UBC. Those biomarkers are processed here by Dr. DeMarco in her lab. Neurologists in the Lower Mainland, for example, here at St. Paul's and VGH will do the testing. There's some just very specific way that you have to collect the CSF in order to reduce false negatives. So theoretically, anyone could do it. So if that's something that you would want to do, then you can get in touch with me or the Alzheimer's clinic. Plasma biomarkers are also available. Life Labs recently made available a only privately funded option that patients pay for a variety of different tests like p-tau217, which is the most recommended right now for plasma biomarkers. It costs in the range of like $375. There is another test that's becoming available again through Dr. DeMarco here at St. Paul's and MSJ. It's going to be reserved for only providers who are specialists in the area of dementia care. So if that's something that you're interested in getting your patients access to, then I would recommend referring them to your friendly neighborhood geriatrician or neurologist.
Thank you.
Any questions from the audience? Christine.
Yeah, that was great. Thanks. I am a neurologist, and so I'm anxious and excited about this. I have a comment and a question. I think when it rolls out, it'll be UBC and VGH community imaging.
Yes.
One of the things that I'm worried about is the imaging work and how we're going to keep access for other people. And I think that's something that's going to be huge.
Mm-hmm.
My question to you is, given the fact that we're moving towards mile, I think that's the only way we're going to make any advances is targeting early. And the geriatrics and neurology, we don't have capacity. So how do you see that liaising with family practice, and how does that tie in with the Center for Healthy Aging and the music policy?
Yeah, just for the people on Zoom, the first comment was about MRI access. I totally share your concerns. I think we all do. Like, how will people get all these MRIs when the wait time for MRIs is like astronomically long right now? Thankfully, we have some really wonderful colleagues in neuroradiology who have essentially assured us that these people will be scheduled for MRIs in a timely fashion, which is really amazing. The impacts and the downstream effects on the healthcare system and other patients is not to be dismissed. And I don't think we really have a full appreciation of what that will look like. I guess the good thing is this is going to be rolled out very slowly with a very small number of patients to begin with. So hopefully it won't cascade astronomically at the beginning, and we'll have some time to catch up with it. The second question you asked, now that I've answered the first question, I completely forgot what the second question was about. About early diagnosis system, yes. Yes, how will we as a system accommodate early diagnosis? This is a really huge question. I don't think that these drugs in this form are going to be prescribed by general practice providers. They're going to require too much monitoring and specialty care. The way that this has been rolled out in the US is that it's still given out really, honestly, in the US, primarily neurologists are prescribing this. And we're going to need to train up more specialists in this area in order to accommodate. I think that some of the other resources to think about are like just the testing and the ApoE4, the plasma biomarkers, the infusion centers, consequences, all thereof. We'll see, but I think it's going to take some growing pains. I don't know, but I don't think that primary care is going to be the one to prescribe.
Doing the screening and all of that, because we don't have the capacity to take on every referral from, so I think we have to build that out. Yeah,
yes, primary care is overstretched at the very least. And I think that we probably both see that in our practice, like what kind of referrals we get and how hardworking they are and how pressed they are for time. We are working on developing like a specific pathway that outlines the step-by-step approach for community providers to refer people to get access to these drugs. That would be a pathway used both at the CARD clinic at UBC, as well as in Victoria, where there's another great clinic that does a lot of this work. So hopefully making it streamlined is at least one way to help.
We also like to bring this new Center for Healthy Aging into the whole and look at the entire spectrum of care for cognitive impairment, not just the drug, but making that maybe the hook.
Yeah, I mean, there's
All the lifestyle.
there's so much research out there that there's a lot of logistical barriers to implementing, but we know that they're good and they're safe. Exercise, cognitive strategies, OT. And right now, it's really hard for patients to get access to this. And it's really hard for people who have more severe impairment. They need an advocate, et cetera. So I think it's really exciting to be able to implement all the other things that we know. To be honest, some of the data reflects that it's just as beneficial for patients to do not like aggressive, quote unquote, non-farm strategies. And so maybe there's a world in which this is part of the equation and people come in and get wraparound care like what we do in cancer care.
Couple questions. Shared decision-making in someone who's dementing, how do you justify that?
Yeah, it's a very good question. Most of the people who would be eligible for this treatment are able to consent to this therapy themselves. People who have progressed a bit farther would be in the moderate stages of dementia. That's when people start to lose more of that decision-making capacity. That being said, there's always exceptions to that rule. And a lot of this will be sitting one-on-one with people and repeating the conversation, reviewing it multiple times, checking in with their family about what matters most to them, what they're willing to go through. The consent form for the prescription does require that the patient provides at least some verbal and written consent. So these are patients that for right now will have to be able to provide that consent themselves. Yeah.
And the other question, or at least observation, is the one that you've brought up over and over, and Dr. Chapman mentioned, and the impact on the system of caring for just one of these people, independent. I mean, how many times? I mean, and the interpretation of the MR. I mean, stroke is a very common problem. I mean, every time a patient with this drug comes in, it's going to be, it's almost an impossible discussion about. Anyway, having said that, it was a wonderful talk, and it was actually very informative information that I didn't know, but I think we're at the beginning, very, very beginning.
Yeah.
Thank you.
Yeah.